So first, in today's session, we'll discuss about few topics or like few concepts in RPD and in FPD. Then I have added few questions which will be discussed along with the concepts in it. Okay. So first, most of the questions in your fixed partial denture for your like exam point of view, it will be on crown preparation, gingival retraction, and next means the impression materials that are used for recording this fixed partial denture cases. So when they speak about like tooth preparation or a crown preparation, the most common question that arises will be on like what are the finish lines that are used for particular kind of crown. If you are planning to give a metal crown, what will be the finish line you will be using? If you are giving a complete veneer, a complete as a term, when they say like veneer means like a part of a crown. So when they term it as a complete veneer, it can either be a all ceramic restoration which covers the entire tooth structure, or it can be even your metal crown, full metal crown which covers your entire tooth structure. So a complete veneer means giving a complete crown for a particular tooth. So in this case they have prepared, when you see here they have prepared an all ceramic preparation for an all ceramic restoration to receive crowns for 1 1 and 1 2. How I decided, how I came to a conclusion this is for an all ceramic means, see the finish line, it is more of a flat shoulder kind of preparation, which, and the reduction is, to be precise, it will be more than, or it will be around like 2 mm even in the finish line regions. So this will be is for an all ceramic restoration. So when they, and other questions that they will ask will be on like what is the degree, what is the taper or the degree of taper that you have given or achieved for preparing to get a proper retention or a resistance form. So when they ask, if the question ask only what is the degree of taper that is ideal, if they ask me the degree of taper, when they say the term, it is for only one side. When they ask like the sum of the degree of taper or a degree of convergence, if they ask like together for a convergence, then it is a combination of the taper on both sides. Just imagine if here it is like 3 degree and here it is like 3 degree of taper. When they ask what is the degree of taper for this preparation is 3 degree. When they ask about like degree of convergence, means it will be a combination of both, so it will be around like 6 degrees totally. So when you speak or when we discuss about this crown preparation, the main thing that we should note is the resistance form. That is, once you prepare and give a crown, your crown should not dislodge. So that, so till what angulation I can go or till what level I can keep the preparation is completely given by Dr. Lewis and Zuckerman. Three people actually gave the concept like what till what level you should prepare, on what angulation you should prepare. But the concept given by Weed was like failed because it didn't, what to say, it was not properly approved, or it didn't have any like it didn't have any hypothesis that will valid his concept. So first we'll speak about the concept given by Dr. Lewis. So what he did, so most of our preparation will be kind of an trapezoid kind of preparation, which has a sites like A, C, D, and E. So in this preparation, if a crown preparation is something like this, so what he did, Lewis stated that to have a retention form, like which part of this preparation will act as a retention or a resistance form for his crown, he stated like to take a this direction or this line with joining point A and point C, make a bisecting line which will join the point E. So he made a bisector line which joins from point E to the center of this AC, and which is marked as B. So the part from B to C, so this portion is considered as an resistance form which was given by Dr. Lewis. So the Lewis method of evaluating the resistance form for the side AC is applied by extending a perpendicular line to the side of AC which extends from point E to B. So the intersection of the Lewis line on the side AC is point B. So all the points occlusion to B. So the point which is for, or the area which is found above B is called as the area of BC, are resistant, are resistive, and all points gingival to B. That is all point which is located here. That is the region which is covered in this AB region or not resistive. So for this kind of preparation, the resistant form is given from this region, that is your BC. So this was given by Dr. Lewis. So one more guy, one more mathematician called Zuckerman, he also gave a similar kind of concept where the same results were obtained with the Zuckerman circle, where all the points that is, so he didn't do anything. So Zuckerman, what he did, he measured AE and the mean value, that is the radius he took from O, and he made a circle from AE. So after making this circle, when the point or the area which is found outside the circle, the preparation that is found outside the circle, so this region is found outside the circle and this region is found outside the circle. So the area of the preparation that is found outside the circle is a resistive form, and the area which is present inside or within the circle is not a resistive one. So to be frank, both this Lewis and Zuckerman gave in a circle manner, and Lewis made it like a bisector one. So but one more guy called Weed, he also gave a similar kind, but it failed because according to Weed, the area which is present within this circle, that is AW, if you draw a circle from here to here completely means, so this region or this AW circle, the area which is within this circle will be a non-resistive one. In that case, the whole tooth which was prepared will come under within this AW. So which if it's not resistive means your crowns won't stay. So this concept given by Weed was not valid. So most commonly accepted was given by Dr. Lewis and a mathematician called Zuckerman. So if they ask like on what basis you determine the resistive form of your preparation, if they give any author's name or the guy's name who formulated means, can go either with Lewis or Zuckerman. Zuckerman gave in kind of a circle one. So this picture will show you have your tooth here. This is the prepared margin. This is the prepared tooth surface. This is the prepared gingival margin, and this is your soft tissue. You can call it your gingival, and this region is your gingival sulcus. So in three pictures, picture A, picture B, and picture C. So picture A depicts your retraction for the soft tissue to properly record your finished line. So here they have used a dual cord. So this is the cord one, that is the primary cord. This is the secondary cord that is placed. And in picture 1 and 2, they have placed or they have restricted only till a single cord kind of technique. So when you will go for a single cord or when you will go for a double cord or a dual cord techniques, if the gingiva, if the gingiva is like thin and fragile, not in every case you will have a thick gingival sulcus or thick gingival region. When your gingiva is like thin, it is ideal to restrict to a single cord technique where you will place a single cord, tug around the tooth completely, then before taking an impression, once you place this cord, the cord can be either a plain cord or whether it is soaked with any hemostatic solution. If it's soaked and then you place, should ideally wait around like 8 to 10 minutes before proceeding for your impression stage. Okay, so once you place your cord, wait for 8 to 10 minutes, then apply little bit of water around this cord, because the cord after placing around like 8 to 10 minutes, it will loses its hemostatic agent that was given to the cord. It will get absorbed by the tissue, or it will get absorbed in your gingival sulcus region. So when you're trying to remove the cord after 8 to 10 minutes, high chances this cord will get adhered to the soft tissue or the gingival sulcular region. So you will unnecessarily tear the tissue that is present around the cord. So before removing after 8 to 10 minutes, apply little bit of water in the cord or the cord that you have packed. Then you can easily remove and make an impression immediately. When the gingival biotype is like thick, or the sulcus of the gingival sulcus is like too large or too long or too depth, to say frankly, if the gingival sulcus is too depth, then it is ideal to go for a double chord or a dual chord impression technique, where the first chord or your primary chord that is placed will be of a smaller size than the secondary chord, or that is placed above. So in this case, when you are making an impression, at the time of making impression, you will, after placing both the chords, you will wait for 8 to 10 minutes. After 8 to 10 minutes, you will remove the secondary chord or the chord that is placed superior to the primary chord. But you won't remove your primary chord or the smaller chord that you placed initially. This smaller chord will be picked up in the impression when you are taking. So this small chord or smaller chord or the primary chord or the first place chord will be picked up in your impression, but the secondary chord should be removed before you're taking your impression manually. And the most important thing when you see, or like when you deal with your fixed partial denture kind of condition, you will come across something like occlusion. So what occlusion should be given for when you're planning for a full mouth rehabilitation, those things and all. So for a full mouth rehabilitation, there are different concepts of occlusion, like your canine guided occlusion, your mutually protected occlusion, your group function occlusion, so on. So but the most commonly given occlusion pattern for your fixed partial denture kind of processes is your canine guided or group function. When to give canine guided or when to give group function? If a patient is having an existing canine guided occlusion and you are rehabilitating only one side of the patient's dentition, then it is ideal. Or if the patient is of young age, it is ideal to restore with a canine guided occlusion. If the patient is having any mutilated condition, there you are trying to establish of the patient's age is like more than like 40-50, there you can go for a group function occlusion or a mutually protected one. So for both this, like when you're fabricating an occlusion for patient, it is ideal to use a semi adjustable articulator. A fully adjustable articulator, most of the people won't know or won't use. So it is enough to use an semi adjustable articulator. Why or like a semi adjustable articulator or an archon type of articulator? Why we should stick with an archon or non archon? Why I can use either one of the articulators, right? Why I have to go for an articulated archon type of articulator? So archon type of articulator, as the word suggests, it is archon, articulating condyle. That is, it mimics like how we have our jaw condition. In your natural or in your human being type, the jaws, your condyle will be located in your mandibular arch, but the fossa will be located in your maxillary one. So in similarly, when you consider this picture A, so imagine this replicates your condyle. So it is attached to your mandibular member. So this fossa that is attached to your maxillary member. So when you see this your, if this is your condylar path, this line is your, it represents your condylar track or condylar path, and this line represents your maxillary occlusal plane. So when the angulation is, when you join both the lines, you will get an angulation which will be same even when you open your articulator or even when you close your articulator. This angle will remain same, it won't vary. But this A and B picture depicts it is an archon type of articulator, that is articulating condyle, where condyle is located to your lower member but the condylar tract is located to your maxillary member. In picture C and D, this is not an archon type, it is a non-archon type, where if you see to this mandibular member or mandibular, this is your mandibular region, your condylar tract is located, but this point that is your which represents your condyle, so that will be attached to your upper member. So in this case, when it is open, the condylar tract angle and your maxillary occlusal plane will be forming an angle A3. But when it's completely closed, your condylar tract will comes to the center of the condyle. So when that time, when you draw a line for your maxillary occlusal plane and this condylar tract, if you join, it won't join or it won't be a similar angle of A3. It will cross and it will join somewhere in front, that will form a separate angle called as an A4. So this is what a basic difference between your articulating or archon type of articulator or a non-archon type of articulator. In your archon type of articulator, your angulation that was formed between your maxillary occlusal plane and your condylar tract will remain same even if you open and close, give any movements. But in your non-archon type, it exactly varies. So it is ideal to use a semi-adjustable and an archon type of articulator when you're planning for your full mouth rehab or any fixed partial denture kind of rehabilitation. So coming on to the instruments that are used for fabrication of wax pattern for your crowns, there are like many different instruments. So most commonly used or most often used is your PKT instruments. So PKT is based on the guy who devised these instruments called as Peter K. Thomas. He has given like a variety of instruments, but the most commonly used for making a wax pattern for your occlusion for your like crowns is your 1 to 5 set of instruments. So in your exams they might ask like, oh, what is the PKT2 is used for, what is PKT3 is used for, what is PKT4 is used for. So your PKT1 and 2, basically it looks like a slender thin instrument. Both PKT1 and 2 is ideally used for wax adding instruments. So both are called as wax additional instruments. So with the help of these two, you'll just add wax in droplets from the wax bath and you'll try to build the overall contour, overall bulk of your crown. So PKT1 and 2 is ideally used for wax adding instruments. PKT3 is used for burnishing. So when you look closely, it will have a cone shaped burnisher kind of instrument will be located on either side. It is used for burnishing. So PKT4 and 5, it is used for finishing or carving the waxes that was like to give the final carving of the contour for your like wax pattern. PKT 4 and 5 are used. So this PKT was devised by the guy called Peter K. Thomas. So these instruments are used for preparation of wax pattern for your fixed partial or like any wax patterns basically. So PKT 1 and 2 are wax adding instruments, PKT 3 is your burnishing instrument, PKT 4 and 5 are wax carving instruments. So coming on to RPD, like you have like various different types concepts that can be dealt in a one whole day. It will take, if you deal for all the concepts, it will take a one complete day. So the most common concepts that will revolve around your exam point of view or questions will be like, what are the lever principle, what is an inclined principle, what is a wheel and axle principle. So basically remember the lever kind of principle, that is when you have a lever you have your fulcrum, load and effort. So thus that kind of lever principle will be seen in all type of your Kennedy's class 1 and class 2 kind of cases. Your inclined plane or inclined principle will be noted or will be seen in your where you're placing your rest and rest seat preparation, or where you're placing your occlusal rest or your canine rest. This inclined principle mechanical force or concept will act. So lever principle will be seen in Kennedy's class 1 and class 2 kind of cases. Inclined principle in the occlusal rest and canine rest and retainer kind. Then wheel and axle principle is basic rotation around the fulcrum line of your cast partial denture. Okay, so the processes that is constructed can either be a tooth supported one or tissue supported one. Tissue supported, that is your Kennedy's class 1 and class 2 RPDs or dentures will be of tissue supported processes. Your Kennedy's class 3, which is bounded on either anterior and posterior by your teeth, will be a complete tooth supported prosthesis. So coming on to the clasp configuration, this is one more question that was commonly asked in your exam point of view. So this is your Kennedy's class 3, where you can see two natural teeth is bounded anterior and posterior to it. So in this case, you have your fulcrum lines running from this primary abutments and this primary abutment and along this side. So you have, to be frank, four different fulcrum lines running, 1, 2, 3 and 4. So since you have a four different fulcrum lines running in this process or in this condition, it is ideal to go a quadrilateral kind of clasp configuration. That is, you have your clasp designing on all four abutments that is used for your RPD designing. When you speak about, when you go about your class 2, that is like unilateral edentulous, in another side you have your teeth that is positioned anterior and posterior to it. In such case you have a three different fulcrum lines, one fulcrum line running from here to here, one along the arch side, and one fulcrum line joining the opposite arch. So in this case, depending on, since they are having three different fulcrum lines, it is ideal to go for a tripod kind of clasp configuration, which is tripod that is usually seen in your class 2 cases. Your class 3 will have a quadrilateral kind of classification of clasp design configuration. When you speak about your that is your like Kennedy's class 1, so one fulcrum line will run around here, another fulcrum line which will be similar of both sides. So this fulcrum line will be similar, which will run here, and one more fulcrum line will run here. So since it is having two main, that is your one fulcrum line which is running in the posterior teeth. So this classification or this clasp configuration for your Kennedy's class 1 will be of bilateral kind, where in most of your Kennedy's class 1, the clasp configuration that is a bilateral one, which will be an RPA system, that is mesioocclusal wrist, proximal plate, and I bar. This is your RPI given by Crowdchow. So RPA stands for mesio-occlusal rest, R for rest, and proximal plate P, and I bar. So in most of your class 1 Kennedy's class 1 type of configuration, your clasp configuration will be of an RPA on either side with an indirect retainer in the canine region. So when I discussed earlier, the most common mechanical force type to play in Kennedy's class 1 and class 2 is your lever principle. So this lever principle is based on the fulcrum lines that run around. So when you consider this many concepts, you can see a fulcrum line here, fulcrum line here, fulcrum line here, fulcrum line here. You can see n number of fulcrum lines in the scene when the patient is having a more edentulous region. So this concept or this lever kind of principle, where you have your fulcrum and you have your effort. So the fulcrum, so this is the processes which is having a clasp assembly or like your direct retainer attached to this natural teeth. So when it is like this, high chances when a sticky food or some food gets stuck here to your upper jaw, when the patient tries to open mouth, this region getting stuck to the upper will try to lift. So this region will act as a lifting area. So that time, which means the effort is happening here. So when you consider it as an effort here and a fulcrum point from point around which your plane can rotate, so that is your fulcrum point. So to avoid or to prevent this from lifting, when you give any opposing force, something which is farther from your effort region, that is on your natural teeth, so this effort will get compensated by this load that is given here, and your lever can be balanced properly. So that is mostly usually seen in your Kennedy's class 1 or class 2, that is your distal extension kind of cases, where you have your fulcrum at the primary abutment and effort at the distal most region. So this R point generally is for the indirect retainer, which helps to compensate or nullifies the forces that are given by an effort region. So coming on to few questions. Tapering fissure diamond burr is subjected to produce a degree of convergence in a tooth preparation. So this is your tapering fissure burr. So when you actually take or measure and see, one side of your tapering fissure burr will give an degree of taper around like 3 degrees. But the question here is like degree of convergence, which means 3 degrees plus 3 degrees together gives your degree of convergence, which is around like 6 degrees. So when you speak about this diamond points, not burrs, diamond points, so you have like different type or different shaped diamond points. So first, when you see about color coding for your diamond points, you have your green color, blue, red, and your yellow. So when starts from green means green is more coarse, this is medium coarse, this is less coarse, this is fine. So when you see the pictures itself, you can see how the variation of course of your diamond points that is located in a green banded bar. When you see blue, it is like less. When you see the red banded one, it is little more less. When you see your yellow banded diamond points, it is like more fine when compared with the other three. So these are different types of burr that are used for preparation. So this is your tapering fisher burr. This is also your tapering fisher with a round ended. So this is your straight fisher. You have your like round burr. You have your, this is called as double cone burr. This is called as a rugby burr or a football shaped burr. So this double cone burr is ideally or mostly it is used to prepare your occlusal surface of your maxillary or your mandibular posteriors. So this burr is exactly held in a horizontal position and it is run over your maxillary or mandibular teeth. So it automatically, so this cone or this V shaped will give the cuspal eminence or like the preparation that was according to the cuspal eminence. So this V shape will give. So you have like different types of burr. First burr is your parallel sided or a flat end burr that is used to give depth grooves. Your occlusal or a buccal depth grooves can be given with the help of this flatten or a straight fisher burr. Then you have your flat end taper burr. This is a long round end taper burr. So both are tapering fisher burr. This is of a flat and short. This is of a long round end taper burr. So this short or flat and taper burr is generally used for any large groove preparation, box preparation, axial or an occlusal surface preparation. Your long round ended taper fisher burrs is used mainly for your occlusal surfaces. For your proximal surface, a same taper fisher can be used, but it will be of a longer one, but the thickness will be of very small. It will be almost kind of a needle shaped burr. So this long needle also a taper, but the taper here or degree of convergence will be more when you compare with your regular taper fisher burr. So this is your rugby burr or your football shaped burr, ideally used to prepare the lingual or palatal surface of your maxillary anteriors. So this smooth ended taper burr, which is your like yellow banded burr, it is used to refine margins and your finish lines. So when they ask about degree of convergence, it is a combined of both the taper degree on either side. Okay. So next question is on stamp cusp reduction for a gold alloy crown is. So when you speak about your crown preparation, next things or next questions that will be asked about like how much you should prepare for your like axial surface, how much you should prepare for your uh, occlusal surface. When you speak about an occlusal surface, how much you should prepare in a functional cusp or a non-functional cusp. So the term stamp cusp may little bit confuse you, but the term stamp cusp is exactly your functional cusp. Why they call it as a stamp cusp? Stamp cusps are nothing but the cusp that fit into the fossa. So when you see here, your maxillary palatal cusp is your functional cusp or your stamp cusp. Your mandibular buccal cusp is your functional cusp or your stamp cusp. So the functional cusp are your the lower the lingual upper cusp and the buccal lower cusp. Your non-functional cusp are your buccal upper cusp and lower lingual cusp. So when so the two key points here is your stamp cusp production, that is your functional cusp production, and what is the type of crown that you are planning to give. Here you are planning to give a gold alloy crown. So for that, how much preparation should I should prepare ideally? So when you go for a gold alloys, the functional cusp preparation should be around like 1.5 mm and non-functional cusp should be around like 1 mm. For your metal ceramic restoration, your functional cusp will go from 1.5 to 2 mm your non-functional cusp in your axial regions, everything and all, the preparation will be around like 1 to 1.5 mm reduction. For your all ceramic, you can blindly tell 2 mm overall preparation is required. Okay, additional thickness of preparation is necessary in the region of functional cusp of the tooth. Why? Because it bears the maximum amount of load during mastication. So when this upper and lower cusp come in contact, your maxillary palatal cusp will exactly transmit the forces here. Your mandibular buccal cusp will exactly transmit your forces here. So both this maxillary palatal and mandibular buccal cusp, which are your which is your stamp cusp or your functional cusp, will bear or transfer the maximum load during your mastication. So it is ideal to prepare more amount of tooth reduction is given in both this cuspal region, mainly for your structural integrity of your prepared crown. So a radial shoulder finish line gives, basically it gives what? Whether it gives your marginal integrity or your structural durability or your periodontal preservation or none of the above. So there are like few guidelines that were given, like which will be useful for you. So when they speak about your occlusion reduction, it is for your structural durability, because with the giving good amount of occlusal reduction, you are giving space for your crown. That is, you're giving space for your metal ceramic or your all ceramic or your full metal crown. You're giving space, thereby getting the structure more durable in that region. So your functional cusp bevel, which is we discussed now, for gold it is 1.5, for your metal ceramic it is 1.5 to 2, for your ceramic or your all ceramic it is 2. So the functional cusp bevel is also given to get a good amount of structural durability in that region. So when you speak about radial shoulder, that is your normal shoulder preparation, it is mainly for your periodontal preservation. All the finish lines is for periodontal preservation. Along with that, when they say if it is a chamfer kind of margin, it is mainly for marginal integrity. Okay, when they say about it is for as a radial shoulder or a shoulder, it is mainly for the structural durability, because you give this radial shoulder kind of finish line for your all ceramic preparation, where the finish line or the amount of preparation is more when you compare with your normal chamfer kind of preparation. By giving more amount of space, you are giving a durability for the structure that is going to replace this region. So that is your all ceramic case, you have your full zirconia and all. So when they say about a chamfer finish line, it is mainly for marginal integrity. When they say about shoulder or radial shoulder finish line, it is for the structural durability. And when they say about gingival beveling and all, it is for mainly for this marginal integrity. So coming on to the other type of like bridges, you have your resin bonded bridges. The funnel shaped perforations through wing like retainers to enhance resin retention is seen in which kind of your resin bonded bridges. So when you say about resin bonded bridges, can classify basically into mainly three types. One is your Maryland bridge, then is your Rochette bridge, then is your Virginia bridge. When they give picture based questions and they ask you to find which is what means, when you have your Maryland bridge, it is just a plain wing which doesn't have any perforation or any mesh type of pattern that is located in it. It will have a plain metal, a complete wing kind of preparation that is seen, mainly used to replace your mandibular anteriors, or when you are planning to replace your maxillary laterals. Only in these two regions, ideally you use your resin bonded bridges, or in some cases when you're giving as a temporary processes, that is you have placed an implant, you're planning to wait for 1 month or 2 months, that time to avoid preparation of the adjacent teeth, you can give a resin bonded kind of bridges. So when they ask about which is, when they ask to identify which is Maryland bridge, will have a wing which doesn't have anything. But when they say about funnel shaped perforations, so any perforated large perforation seen means that is your Rochette type of bridges. And your Virginia bridge will have something kind of a mesh that is located to your bridges. So coming on to the next question, if the molar teeth or tooth is extruded more than how much extraction should be considered? So the options are 2, 3, 2.5 or 3.5 So why this molar extrusion is like happening, or why it is a big issue? Because see this case where your first quadrant, that is your 1 6 and 1 7, because of absence in the opposing contact, is as like completely extruded. There's both the molars are like supraerupted, and it is almost like occupied the pontic space or the prosthetic space for the fourth quadrant region. So not every time you can manage such cases. So their question was like, till what level, if it is like extruded, you can manage, or beyond which, if it is excluded, you should consider it for extraction. So if the teeth, so from the adjacent tooth which is in occlusion with the opposing teeth, from this level, when you take a line and draw from this level completely, see how much the adjacent teeth has like extruded or supraerupted. If the tooth is supraerupted like 1 or 2 it is fine. You can do certain things to manage and give a prosthesis. But if it extruded more than 2.5 to 3 then it is ideal to extract and consider some other option. So what are the options that are can be considered if it is extruded till 2 If the tooth has extruded only till 2 so see here, this has not extruded much. So they are managing this tooth by intruding it, by using a mini implant and an orthodontic intrusion. This tooth is managed, so it will be extruded less than 2 So with the help of this orthodontic brands and mini implants, they are intruding this tooth, and so that later they can use this space for prosthetic replacement of the missing teeth. One more kind how they can manage is like by doing an intentional root canal for this tooth and giving a crown. So after doing intentional root canal, you can prepare more than like guided tooth preparation levels. Thereby you can gain space for this opposing tooth replacement. So if the molar tooth is extruded more than 2.5 extraction should be considered for that supraerupted teeth. If it is less than 2.5 you can manage with orthodontic intrusion or intentional root canal followed by a crown for that particular tooth. So in a clinical scenario, in second quadrant, you have your 2.4 and your 2.6 missing. Your 2.3 is firm and good. Your 2.5 is like a little bit mobile, like say if it is in grade 1 or less than grade 1 mobility. Your 2.7 is like firm and good. So what kind of connector you will be using for this, replacing with a fixed kind of prosthesis? So ideally, this condition is termed as a pyre abutment condition, where pyre abutment is a lone standing abutment which will get force from the pontic replaced in the 2.4 region, from the pontic that you will replace in the 2.6 region. So in ideal condition, if your 2.5 is not grade 1 mobile, it is also firm, it is ideal to go with a non-rigid connector or a tenon mortise or anything you name it, you can go. A key and keyway kind of connector can be used if your 2.5 is a firm type, where this portion from canine premolar to your second premolar will be one part or part one of your processes, with having a key attached to this your part one kind of process. Your keyway will be attached in the second part pontic, which will be replacing your 2.6 and 2.7 region. So when a single tooth which is having a missing tooth on either side, and you should replace this complete arch, it is ideal to go for your pyre abutment processes, that is you giving a non-rigid connector, that is your key and keyway kind of connector. But here in this condition they have mentioned grade 1 mobility of 2.5. So in that case, if you give a key or a keyway kind of connection, this is already grade mobile. So whenever this process if comes in contact with the opposing arch, some amount of forces will get transferred to this region, which is already a grade 1 mobile. So it will still go on from grade 1 to grade 2 in upcoming years if you are giving a non-rigid or a keyway kind of processes. In such cases, you should avoid this and give a complete 5 unit bridge encompassing this also as an abutment. Thereby what you're doing, you are kind of splinting this mobile teeth to the processes. Thereby you are avoiding the increase in the mobility of that particular tooth. Okay. So when the condition kind of like a pyre abutment, if your 2.5 is not a grade 1 mobile, you can go with a non-rigid connector. If it is grade 1 or grade 2 mobile and you want to include it for your prosthesis, yes, you should give a connector which is of a conventional rigid type of connector. So when you speak about your abutments, you have different abutments like your tilted abutment, your cantilever, your pyre kind, that is what we discussed, and your post and core abutment. So tilted abutment, nothing where you should give a. So one more question arises like, till what degree of tilt I can manage a tooth? Say if the teeth is like tilted like 5 degree, 10 degree means with the preparation I can manage. But if the teeth is tilted from 17 to 25 degree, if it is more than that kind of tilt means you can't do anything, you can't manage with your conventional processes. You should try something like your telescopic crown, or you should try this pyrabutment, that is your you should try this non-rigid connector kind of processes for that particular tilted tooth. If the tilted tooth is around like 10 degree or like 12 degree, yes, you can manage with a conventional crown preparation itself. If the tilt is more than 17 to 20, you should consider for giving different other types of processes, giving a non-rigid connector or a telescopic crown, something like that. So coming on to the favorable crown root ratio of an abutment tooth. So favorable, you have your 1 is to 2, 2 is to 3, 1 is to 1, and 2 is to 4. When you say about your crown root ratio, remember that is your ideal crown root ratio should be 1 is to 2. That is your 1 is your clinical crown, 2 portion is your thing that is found beneath or below your soft tissue. So 1 is to 2 is your ideal crown root ratio. Optimal is your 2 is to 3. But a favorable, which can like favor to give your processes, is your 1 is to 1 kind of preparation. 1 is to 1 kind of crown root ratio. For you to have an ideal abutment, it is 1 is to 2. For you to have a favorable, it is 1 is to 1. If it is like not satisfying all these three, it will goes in unfavorable condition, where you should include one more abutment for giving a prosthesis. And one more question, when a teeth is in grade 1 or mobility, and should I consider it for preparation, or should I extract and consider the adjacent teeth? Means when the teeth is in grade 1 mobility or little above grade 1 mobility, you can still keep the teeth and use it for preparation. In that cases, you should increase the abutment numbers. So imagine if this tooth is in grade 1 mobility, this all teeth are fine. So should I remove this teeth and take this as an abutment and give a processes? Means no. In that case, you can hold this tooth, you should prepare this tooth, and you should include this canine also and give a 4 unit processes. Thereby you are splinting this mobile teeth. So previously when aunties gave certain laws for like how to for, sorry, this divan gave certain principles like what to include, what not to include, and auntie's law and all. If you see means, when the teeth is like mobile, they won't advise you to save the teeth, and they will ask you to extract and consider the teeth which is firm. But later, a guy called Johnston, he Johnston and Neymar, they did many like back dating of the cases that was given in various parts of world, and they found if the teeth is like mobile, and if you take an extra abutment support, the mobile teeth also will get a splintered action, and it doesn't improve any further in its mobility region. Sometimes the mobility will get reduced also. So So in that cases, if such in such cases, if the teeth or a primary abutment, if it's having a grade 1 mobility, it is not advised to extract. Instead, you consider the adding one more extra abutment for that particular prosthesis. So when a question comes, the first professionally recognized classification system of RPD means, don't go directly to Kennedy's as most commonly RPD classification that what we know is Kennedy is not the first professionally recognized one. It was given by Dr. Cummers. So Kummer in 1920 he gave this recognized classification, but your Kennedy's classification was given 3 years later, that is in 1923. So, what is the classification that is given by Cummers for your removable partial denture? According to him, the partial dentures can be classified into four different types like diagonal, diametric, unilateral, or multilateral, depending on different like where and all your teeth is missing. So two direct retainers are diagonally opposite to each other, considered as diagonal. Two direct retainers are diametrically opposite to one another, means is diametric. This is unilateral on same side, multilateral on both sides. So the first professionally recognized classification was given by Cummers. When you say about Kennedy, it was given 3 years later, that is on 1923. So as you all know, class 1 is bilateral edentulous, class 2 is unilateral, class 3 is having natural teeth anterior and posterior to it, class 4 is single bilateral edentulous locating anterior to the remaining natural teeth. So but the question what they ask will be of like, which Kennedy's classification is more common, or the frequency of occurrence is more, though that is how the question will be framed. So when the such question is asked, class 1 is the most common kind of RPD classification that is found in most of the patients, whereas class 4, that is person having a single bilateral edentulous area located anterior to the remaining natural teeth, class 4 is like very least. Class 3 will go for a fully tooth supported process. As previously I mentioned, your class 3 is your fully tooth supported processes. Your class 1 and class 2 is a tissue supported processes. Tissue supported or a tooth and tissue supported processes. So later, with the help of Applegate, he modified this Kennedy's classification by extending two more classes like class 4 and class 5, which is based on how your natural teeth is supported in your class 3 kind of condition. So coming on to thing called as survey line. So survey line is nothing but your, when you take a tooth and draw how much bulge the tooth, when you take a pencil and run around the tooth, there will be a line drawn over the contour or like highest contour of your tooth. So that line that is obtained from that particular tooth with the highest contour is called as your survey line. So considering a survey line is more common in canine and premolar. When you say about your survey line, you have like different types of survey line, kind of like high survey line, a medium survey line, a low survey line, or your diagonal survey line. So this, to make this little bit easy, like how this high survey line is like located, how this medium survey line, how this low survey line, how this diagonal survey line is located, you should divide. So if you are planning to replace the missing teeth in this region, and this is your primary abutment for your removable for your cast partial denture. So in this primary abutment, divide it into half. So one half which is located towards your edentulous region is called as near zone. One which is located to the adjacent side or towards which the teeth are present is called as your far zone. So dividing the teeth into near zone and far zone was given by Louis Blatterfin. So when they say a thing is or a tooth is having a high survey line, means the survey line runs from one third, that is your occlusal one third of near zone to the occlusal one third of far zone, that is your high survey line. If the survey line runs from occlusal one third of near zone to the middle one third of far zone, it is your medium survey line. If your survey line runs from cervical one third of your near zone to the cervical one third of far zone, it is your low survey line. But if your survey line runs from occlusal one third of your near zone to the gingival or your cervical one third of your far zone, then it is called as your diagonal survey line. So in your most of your molars, you'll have a low survey line or your medium survey line. And in your anterior teeth, in your like centrals or lateral, if you're planning to get a survey line, there you will get your high survey line kind of condition. But when you speak about like diagonal survey line, it is more commonly seen in your canine and your premolar region. You will get your diagonal survey line kind of condition. So you have your high survey line, medium survey line, low survey line, diagonal survey line. Low survey line seen in molars, high survey line in anteriors. Your diagonal survey line will be seen on your canines and premolar region. So when they ask about like they'll place a for a picture based question, they'll place a surveyor and they will ask you to name the parts, or they will mark and give the parts means. So this is your platform of your surveyor. This is your cast holder. This is your platform. This is your cast holder. So this is considered as a vertical arm of your surveyor. This is your horizontal arm. This is your surveying arm. This is where you will attach your surveying tools or mandrel which attaches your surveying tools for your surveyor. So the most commonly seen surveyors are your Ney surveyor, Jelenkos and Williams. So where the difference exists. So directly your Ney surveyor will have your horizontal arm is fixed. So this is an example of a Ney surveyor. This horizontal arm is like completely fixed in your Ney surveyor. In your Jelenkos or Williams, this can rotate or this can like revolve around this vertical arm. So your Jelenko surveyor and Williams, the horizontal arm is not fixed. Then the other main difference is your undercut gauge. So in your Ney surveyor, you have three different undercut gauge, which will be circular and beaded. In your Jelenko surveyor, you will have one undercut gauge, which will have three different leaves or three different fan extensions. Each wings will measure different undercut. Okay. So the commonly used surveying tool are your analyzing rod, your carbon marker, your undercut gauge. So this single rounded undercut gauge is seen in your Ney surveyor. If it is having a beaded or a fan shaped one, it is your Jelenko surveyor. Now wax trimmer. So coming on to the recording the spatial orientation of a cast is done by a procedure called as orientation, face bow transfer, tripoding, or cast aligner. So, so the face bow transfer is mainly done to orient your maxilla. That is, you get the spatial orientation of your maxilla. You will do your face bow transfer. But when the question is like recording the spatial orientation, you oriented your cast and you are recording it so that you can use it for further purpose means that recording of the spatial orientation of your cast is done by a procedure called as tripoding. So tripoding, the name they got is from your like how you have the three tripods that is used for get a still camera when you're planning to take a still location of a place with the help of your photographs from your camera. You will place your tripod, right? So similarly, same kind in your cast you will mark 3 points. So these 3 points are called as tripod. Thereby the same you are recording the spatial orientation of this cast in 3 points. So the same points can be used when you want to use the same cast in different purposes for planning your cast partial denture. The final cast position must be recorded so that the cast may be later be repositioned precisely. So this procedure is referred to as tripoding. There are like 7 different methods of tripoding the cast. The most commonly used one is you with the help of your carbon marker. You will mark 3 points in one in the palatal anterior slope of palate, two in the either side of your posterior lateral slopes of your palatal region. So this 3 point will form a plane which is recorded for this particular cast. So the same plane of orientation will be used for this cast n number of times whenever you are planning to change the design or fabricate any processes in this cast. So as previously described, a fan shaped undercut gauge is seen in Jalanko surveyor, whereas in your Nace surveyor you'll have a circular beaded type. Okay, so this circular beaded kind of undercut gauge is seen in Nace surveyor. So this fan shape, you can notice 0.01, 0.02, 0.03. So this fan shaped kind of undercut gauge is seen in Jalanko's one. So your undercut gauge is usually used to measure and locate the horizontal depth of undercuts on the analyzed or a marked teeth in a three-dimensional manner. So how much depth is located? So that is measured with the help of this undercut gauge. So there are three different values based on books that are given. According to Stewart, this undercut gauge is like 0.01, 0.015, 0.02. But according to McCracken, it is 0.1, 0.01, 0.02, and 0.03. So in your nace undercut gauge, you have like three different undercut gauges seen 0.01, 0.02, 0.03. But in your Jalankos, you have only one fan shaped undercut gauge, which have three different wings. Each wing will give one value. One smaller wing will give you 0.01, next one will give you 0.02, and another one will give you a 0.03 kind of undercut gauge measurement. A guiding plane should involve approximately how much of the buccolingual width of a tooth and how much the vertical length of an enamel crown or a tooth. So basically, what is your guide plane? So imagine you're planning to replace the tooth here. So your processes will be placed in same direction. So the path of placement of your process will be in this direction, and removal will also be in the similar direction. That time, the main thing we should consider is the what is the undercut that is located in this region. If the teeth is like having more amount of undercut, it is difficult for even you to place the processes. But it's difficult for you to place the process means it will be more difficult for the patient by himself to place and remove the processes. So in that case, to get a proper placement or proper path of placement of a processes, you should plane or you should guide the processes to sit. For guide the processes to sit, you should fabricate a plane so that your process will sit and exit in a same manner. So that fabrication is called as guiding planes. So guiding planes on the teeth, that is, if you are replacing this teeth means you should plane the distal surface of this premolar and the mesial surface of this molar should be planed parallel, so that your processes will sit and exit without any hampering. So in that case, how much should be the buccolingual width of a tooth or a vertical crown? So this vertical, when you are preparing this vertical from top to bottom, you should involve around like at least two-third of your vertical height of your tooth should be involved for prepare this guide plane. When you consider your buccolingual width, so this buccal and lingual width, when you consider, it can be around like one third. So a guide plane should involve approximately one third the buccolingual width of a tooth, or two-third the vertical length of your enamel crown. So it should involve around like one third. So this is your buccolingual width means, so this one third amount of region should be used for your guide plane preparation. When you say about in vertical height, it should be around like two-third, at least two-third you should height of preparation should be used. And even this varies. Okay, so in this case, it is a class 3 kind of condition where you should prepare almost complete or more than two-thirds should be prepared for this vertical height. When you see for a class 1 or a class 2, this can be little bit shorter also. So use a short guide plane for a class 1, class 2. For your class 3 and class 4, use a long guide plane preparation. For a long span distal extension cases, which maxillary major connector is not indicated. For a long span distal extension cases, that is your class 1 Kennedy's class 1 kind or a Kennedy's class 2 kind, the ideal maxillary major connector will be your anteroposterior palatal strap. Most comfortable and most widely used is your anteroposterior palatal strap, until unless the number of missing teeth is more. Okay, if it is having many number of posterior missing teeth, you can go for a complete palate or your anterior posterior palatal strap in that case also. But which one should be avoided or which is not indicated when there is a long span edentulous distal edentulous case means you should not use your horseshoe shaped, because this horseshoe shaped and this is doesn't have any connection in the posterior region. So with the amount of forces and amount of heat transmission this metal takes place, high chances this U shaped will get widened in a long run. So that time when this U shaped gets widened in a long run, it will exactly hamper your posterior teeth. And also in this condition, when you're having a long span distal extension cases, means the extension will be from canine to canine only, or either from first premolar to first premolar. So the patient will be missing your second premolar or other molars and all. So when your extension is only till first premolar in a long span edentulous distal extension cases, and when you're giving a horseshoe shaped in a long run, this U shape will widens because of the forces that are acting on this major connector, and also with the amount of heat that is given for this when the patient is having any hot food or a variation in the amount of temperature for this processes will lead to a widening of this U shape, which will affect easily your abutments. So your hot shoe shaped kind of maxillary major connector should be avoided or is not indicated in a long span distal extension cases. But most commonly used long span distal extension case major connector is your anteroposterior palatal strap or your complete palate. So the common indications for maxillary major connector: when the periodontal support of the remaining teeth is weak or more palate should be covered, you can go for a complete palate or a wide palatal strap. For a long span edentulous, you can go for a closed horseshoe, not an horseshoe, closed horseshoe or anteroposterior palatal strap can be used. A complete palate can be used. If a tori is present, you can go for either U shaped, or that is your horseshoe, or a closed horseshoe if you are able to encompass this tori within the extension of this closed horseshoe, or an anteroposterior palatal strap can be used. When there's a many number of anterior teeth are missing and has to be replaced means you can go for a complete palate or your horseshoe kind of maxillary major connector. So in this table I have like condensed all the different types of major connector and what is the shape, that is what is the advantage, disadvantage, and what are the indications for particular type of major connector. Okay, this I will circulate in the group. So coming on, a swing lock design kind of a major connector, a swing lock design kind of a mandibular major connector is a modification of lingual bar, anteroposterior palatal strap, double lingual bar, or a labial bar. So first identify which major connector it is. Swing lock design major connector is your mandibular major connector. So eliminate this anteroposterior palatal strap. So other things are your lingual bar, double lingual bar, or labial bar. So the swing lock is, this is the swing. So this region, this process will get locked here. So this portion which connect this remaining part will have a swinging action here. So when the lock is released, this labial portion processes can easily swing and can get locked to the. So this is a modification of a labial bar mandibular major connector. So this labial bar or a swing lock design is generally given when the patient's remaining teeth is only mandibular anterior, and those mandibular anterior is also having a grade 1 mobility. Okay, means the swing lock kind of mandibular major connector can be used, thereby it reinforces or it holds the teeth in the remaining natural teeth in same position. So similarly, I have tabulated like the different type of mandibular major connector, what is the shape, advantage, disadvantage, indication, and contraindication for your different type of mandibular major connectors. So the common indications for mandibular major connectors. So if a routinely indicated or first preference of major connector for a tooth supported RPD cast partial is your lingual bar. If a patient is having a high lingual frenum and active tissue of the floor of the mouth, means go for lingual plate. For long span edentulous ridge, that is your class 1, class 2, or an indirect retention is needed, means go for a lingual plate. The anterior teeth having reduced periodontal support and needs stabilization, means you can either go for lingual plate or a double lingual bar. So a large proximal interproximal spaces that could cause aesthetic problem is go for double lingual bar. If there is a extreme lingual inclination of a premolars or anterior teeth or an inoperable tori, in such cases you can go for a labial bar, and also a modified labial bar is your swing lock design can also be used in such cases. Only major connector which is not rigid. So these are the different types of major connector. That is a major connector formed by joining the clasp assembly to major connector. A major connector joining the indirect retainer or an auxiliary rest to the major connector. A minor connector that is joining the denture base to the major connector, or an approach arm in the case of a bar type clasp, means the all other generally your minor connector should be rigid. Why? Because the main action of your minor connector is just a hub or just a joining portion. Okay, if you have different components, you place a minor connector which joins all the components. That is the main work of your minor connector, as the name itself explains, like a minor connector that connects all the major parts. Okay, so a connector should be hard or a strong enough, but there is one place where your minor connector will be little bit not rigid, or little bit a little flexible, or a little non-rigid is where, that is your approach arm in type of your bar type of clasp. So in your bar type or an approaching type of your approach arm kind of clasp, this approach arm will be little bit non-rigid one. Okay, so in this case the minor connector which is not rigid is your approach arm type of bar clasp. So coming on to this picture, which gingival retraction type or technique is displayed here. So when you see this blue color, some impression material kind of which is seen here is right. So this is called as your magic foam. So the gingival retraction type that is used here is magic foam, which will be like available like how your light body is like available in guns. Similarly, your magic foam also will be available in guns with having a disposable tips. So once you're done with preparation, using the tips you can inject the material around the prepared tooth, and this white structure which looks like a tooth is called as your compre caps. So this compre cap is used to hold the retraction material over the tooth structure for a quite some time, so that you will get a good amount of retraction of your gingival sulcus. So the retraction gingival retraction technique or the material used here is a magic foam retraction technique. So this is called as compre cap. So this white tooth structure, which will be like a soft sponge, which will mimic the tooth structure, which will help to push this magic foam into the sulcular region. So the strategic class positioning and configuration for this RPD condition. So the RPD condition here is your class 3. So you will have 4 different fulcrum lines, one running here, one running here, one running here, and one running here. So we'll give a quadrilateral type of clasp configuration for this class 3 kind of RPD condition. So what is the finished line that is displayed here? So the finish line that is displayed here, you can see a flat radial shoulder, a flat shoulder preparation line or shoulder finish line is displayed here. So when they ask like what burr you use to prepare your you use to get this finish line, your answer should be your flattened taper burr. Okay, when you use your like round and taper, you will get your chamfer, or even you use your torpedo kind of burr, you will get a chamfer kind of finish line. When you get a flat and taper, you will give a shoulder kind of finish line. Or sometimes they will give such preparation and they will ask like what is the processes that you can give for this particular case having a finish line of flat. So in that case, your answer should be your all ceramic restoration. When they give a knife edge kind of finish line and they ask, you can go for a metal, complete metal, or a full veneer crown you can give for that particular case. So they have given certain images like this something you can, it looks like a spoon excavator, and this looks like kind of a GMT, gel marginal trimmer. So when they ask what are these instruments, means in your spoon excavator, if you notice, there will be a small depression here which is not seen. This, when you look closely, they will have certain serrations in this image. So these are an example for your gingival cord packing instruments. So these are called as cord packers. Okay, so this is of few Fridays. This is of Fisher's cord packer, different brands giving different type of like cord packers. So mainly this large, so this is the same instrument having different ends. One is small, one is large. This small cord packer or the small spoon shaped cord packer is used to pack the, is used in double cord technique, which is used to pack the primary or the inner cord will be used to pack with the help of this instrument. And this is used to pack your like a secondary cord or your cord which is little bit larger than your primary cord. So this, if you closely watch, this is also a cord packer. This will have a serrations in it, so which will help to pack the cord nicely if the depth is not that much sufficient. If your gingival sulcus is not that sufficient depth, you can use this serrated cord packer to help to pack your cord more efficiently. So are both the instruments of same kind? Yes, both are your gingival cord packers with having different designs. That's it. What is the purpose of this diamond point? So when they ask like what is the purpose of this diamond point, means first see what shape it is. Okay, as I previously discussed, you have different type of diamond points, differences in the shape, how they are oriented or how they are made, differences in the color code that is seen in them. So first here you should notice the color code. So yellow means it is a fine diamond point which is used for the finishing purposes. And when you see the shape, it is more of a rugby or a football. So this is a football shaped finishing burr, oh sorry, finishing diamond point. So this is used in the finishing stages of your palatal or your lingual regions, mainly in your maxillary palatal region, in your anterior maxillary anterior palatal region. Those regions, to finish the region, you use this yellow banded